Welcome, everyone. My name is Catherine Kiefer. I am the Neuroscience Program Manager at Rush University Medical Center, as well as a co-founder and president of the Brain Health Center of the Rockies. I'm excited to welcome you all to our October session, where we will be talking about highlights from ECTRIMS. And we will be receiving this insightful session with three of our leading MS specialists, Dr. Augusto Miravalle, Dr. Thomas Shoemaker, as well as Dr. Jean-Raphael Schneider. Both Dr. Augusto Miravalle and Dr. Shoemaker are at the MS at the Rush University Medical Center and are part of the MS division. And Dr. Jean-Raphael Schneider, he is with the MS and Neuromuscular Center of Excellence in Florida. So excited to have all three of them on board to be giving us updates on some of the clinical highlights from this year's European Committee for Treatment and Research in Multiple Sclerosis. That's the ECTRIMS conference that was just held this past month in Barcelona, Spain. On that note, just a quick introduction of each of our three speakers. Dr. Augusto Miravalle, as I mentioned, he is at Rush University Medical Center, and he leads the MS division and neuromuscular neuroimmunology group as the division chief at Rush. Dr. Tom Shoemaker, he is a board-certified neurologist at Rush University Medical Center and an assistant professor in the Department of Neurology. He practices at Rush in the Rush MS Center, where he focuses on patient care and clinical research. In addition to his clinical responsibility, he serves as a site investigator for several industry-sponsored studies. Dr. Shoemaker is also leads the neurology residency program as its director and oversees the training and development of future neurologists. Dr. Jean-Raphael Schneider is a board-certified neurologist as well, with additional fellowship training in neuroimaging and neurophysiology. His main areas of interest are multiple sclerosis and neuromuscular conditions, such as polyneuropathies, carpal tunnel syndrome, ulnar neuropathy, cervical and lumbar radiculopathies, and muscle diseases such as myasthenia gravis and ALS. Dr. Schneider uses his specialty training in neuroimaging in the diagnostic and monitoring of multiple sclerosis with MRI. His expertise in interpreting MRIs is also very helpful in evaluating nerve impingement in the spine. Dr. Schneider enjoys reviewing imaging studies with his patients to help them understand their diagnosis and treatment. So it is a wonderful honor to have these three specialists here to give us this overview and give us some additional insight in where things are currently and where the future stands for multiple sclerosis. So on that note, I will turn it over to Dr. Miravalle. Thanks so much.
Thank you, Kathy. And I second Kathy's comment. Thank you, Dr. Schneider and Shoemaker, for joining us today. And of course, thank you to our wonderful audience that follows us every month with exciting topics. And today, to be honest, I'm very excited because ECTRIMS is the largest multiple sclerosis research and clinical meeting of the year. Traditionally happens in Europe, and over 12,000 people attend these meetings. This is all the researchers, clinicians, and some patient advocacy groups attend as well. So it's a big celebration of what is happening in research or the excitement around areas of interest, therapies, but also opportunities to rethink about what we've been doing for the last decade or so in MS, and perhaps bring new ways of defining topics in multiple sclerosis. So one of those is diagnosing MS, and we know that the process of diagnosing in MS is not easy. It's not that we have a single test that we can send to the lab and patients actually are diagnosed with multiple sclerosis. I'm sure everyone and each of you went through a similar path, but with some nuances, some differences. Every path is different. And over the years, over the decades, the diagnostic criteria of multiple sclerosis have evolved and changed. And that change is being triggered by new knowledge that comes from research, but also understanding on how certain tools, like for example, the MRI, can assist in the diagnosis of multiple sclerosis. And we were just talking about career path before we started here and how we all end up in MS. And we all have a different path. But I remember vividly when I was a medical student that my mentors will tell me, you don't treat MRIs, you treat people. And that was a concept of saying, so if the patient is stable, but if the MRI is not stable, you just leave them alone. Well, we moved away from that. And we now know that the MRI is a wonderful tool, not only to understand disease processes, to understand whether patients are stable or not, but also to diagnose patients as early as before patients even have symptoms. So nowadays, we actually treat MRIs, even though patients may not have no symptoms. We know that if there is MRI activity, we should act on that. So on that note, Dr. Schneider, what can you tell us about the diagnostic criteria of MS, the use of MRI, which you are an expert, and how we can actually use these tools to help diagnose MS earlier?
Thank you, Dr. Miravalle. And yeah, I agree that the diagnosis of MS has greatly evolved over the past, since I was in training. And when I remember when I was a resident, we had a couple patients that we called MRI negative MS. And now we know that that doesn't really exist. You kind of need the MRI to make the diagnosis. And like all this, the criteria that we use to diagnose MS have been continuously improving, evolving, and this is the 5th revision, and it was actually released last year in Copenhagen. But now in this conference, we have more experience with it, and we're able to talk about its use with some more experience in clinical practice. And like you said, the idea of these revisions is that we use the research, our increased knowledge, to improve the diagnostic criteria so we can have a more accurate diagnosis and also an earlier diagnosis. And so, in terms of the changes that happen with this latest criteria, some of the big changes were the, incorporation of the optic nerve as another dissemination in space. So the big principles in the diagnosis of MS is that you have to prove dissemination in time and space, right? So because multiple sclerosis is a chronic condition that affects us over many years and causes lesions over time. So we want to be able to show that there's been something going on over a period of time. And that's one of the criteria that we want to meet. And MRI makes it a lot easier and to meet that criteria so we can diagnose earlier. And then we also want to improve dissemination in space. So multiple sclerosis, like the name implies, affects multiple parts of the central nervous system, including the optic nerves, which is the only cranial nerve that is part of the, of the nerves, I guess, involved with MS and is part of the central nervous system. So now with these new changes, we're able to diagnose sooner. Now we can use optic neuritis evidence in visual evoked response or ocular coherence tomography and to meet that dissemination in space. But some of the basic principles of diagnosing MS have not changed. And we still require that patients, one of the criteria to help diagnose is that they have to have symptoms that are characteristics of MS, that are specific for MS. And you also want to have no better explanation for why the patient is having the symptoms, like comorbidities. And actually, if patients have comorbidities, then they need to meet more criteria and have more findings to be able to confirm the diagnosis. And then in terms of dissemination in time, we have the gadolinium enhancing lesions. When we see a lesion that picks up contrast on the MRI of the brain, we know that that's an active lesion. And so if we see a lesion that doesn't pick up contrast but has T2, increased T2 signal, we know that that's an old lesion. So if in one MRI you see an enhancing lesion and a lesion that doesn't enhance it but is bright on T2, you already met dissemination in time because you got old and new. But if you don't have that, and you can improve dissemination in time by doing a follow-up MRI, if the follow-up MRI shows either a new enhancing lesion or a new T2 lesion, that would help meet dissemination in time. And then in terms of other MRI findings that can help us confirm the diagnosis that were incorporated with this new criteria, we have the central vein sign, which is very specific to MS. And the requisite is having more than 6 central vein signs. And then the paramagnetic rim lesions. And those are very specific and very related also to disability progression, seems like. And so just having one of those can help diagnose MS. And
So
then
if
there's
I can,
also,
sorry to interrupt, but you said so many things that I'm trying to unpack that because it's a lot of information, but it's also wonderful information. So if I can summarize, so we always talk about the dissemination in space, meaning you have to have lesions in different neighborhoods. I explained that, right? And up until now, we had 4 neighborhoods that we were allowing lesions to be in order to say, yeah, that's a lesion that looks like MS. And now we added a 5th neighborhood, which is the optic nerve. And just for clarification for patients listening, so it's not that in the past we ignore the optic nerve. We always paid attention to optic neuritis or optic nerve pathology, and even for the diagnosis of MS, but as a clinical symptom. We did not use that lesion in the optic nerve as an MRI finding to meet this dissemination in space criteria. So for those of you who were diagnosed with an optic neuritis and that was the way to diagnose MS, this change is not going to change anything on you. And that's one message that I want to convey, that these revisions are not undoing any previous diagnosis of MS. If any, they are allowing patients that perhaps in the past didn't meet criteria to now be able to meet criteria. The other thing that you mentioned that I want to dive a little bit deeper is this concept of the new lesions, the names of these new lesions. And you mentioned 2 that I want to clarify. One is a central vein sign. And that has to do with a little bit of the knowledge of how MS pathology enters, or the inflammation enters the brain. And we had this knowledge that one of the ports of entry is around the veins in the central nervous system in the brain. And that due to this disruption of the blood-brain barrier, these immune cells all of a sudden enter the brain. And Dr. Shoemaker is going to talk more about new therapies, perhaps about therapies that actually crosses the blood-brain barrier in a minute versus therapies that don't. But as they enter, they cause demyelination and damage. And that demyelination wraps around the vein. So the central vein sign is nothing else but our ability now to see that vein in the middle is surrounded by these focal areas of demyelination. And so can all MRIs, Dr. Schneider, show the central vein sign, or you have to have specific techniques in order to be able to visualize that?
yeah, you need to have special susceptibility sequences. And so it's very important that patients get special MRIs that are protocols that are designed to see the findings in MS. And I really like the way you use the analogy of different neighborhoods, and that's a great point. And so you have, because this is the reason I like so much in going into the diagnostic criteria and the MRI findings, is because this is something in clinical practice that we deal with on a constant basis. And just today, I saw a patient who was concerned about MS, and like many people and many patients, and she had white matter lesions, which is probably the most common finding on MRI as we get older. So it's not uncommon, with age, especially if you have comorbidities or you smoke, that there will be white matter lesions. And looking at the characteristics, the particular characteristics of MS lesions can help us differentiate the run-of-the-mill vascular white matter T2 hyperintensities from those that are help us diagnose MS. And so, like you mentioned, the neighborhoods are important. So with MS, things that we look for is the juxtacortical, or meaning right along the cortex, involving the U fibers. So they kind of follow the cortex in their shape. And then you have the infratentorial lesions in the brainstem, in the middle cerebellar peduncles, in the medulla. Those are very specific. And you have the spinal cord lesions. I tell patients, everybody has little white dots in their brain, but if you have them in your spinal cord, that means something. So, if you have spinal cord lesions, and that helps us diagnose. And now, like you said, and the optic nerve in terms of another neighborhood that we look at.
And one of the changes, if I may add to this, one of the changes that came that it's kind of interesting is that in the past we used to say at least you have to have 2 neighborhoods or lesions in 2 or more neighborhoods in order to be diagnosed. But now there is a little bit of a push towards, well, wait a minute, if you have lesions in the spinal cord, for example, but you have multiple lesions in the spinal cord multiple times, and you meet certain criteria, you could eventually be diagnosed with MS. So that's one example in which we are trying to push this diagnosis sooner. And the other type of lesion that I want, if you don't mind to explain, which I think is going to tie very nicely with Dr. Shoemaker's talk, is this concept of the paramagnetic rim lesion. Can you tell us more about how they look and what type of pathology they represent?
Yeah, for that, unfortunately, I would need to be able to show you like an image. I won't have a slide for that. We know that they're very specific for MS, correlated with disability progression. We only need one to help us diagnose MS. Oh, do you have a picture there? Oh, excellent.
I think Dr. Shoemaker is sharing his slide, but yeah, here
we
go.
go.
Perfect.
Can you see it okay right now?
Yes, we can.
Yes. Okay, so yeah, we have the we have the biomarkers too. So yeah, on the left there, we have the central vein sign, and you see how this sequence here is a susceptibility sequence. So it shows us and the vein better. And Dr. Shoemaker there is showing us with the pointer how there's a vein with increased T2 signal around it, and that is a central vein sign. And for that, the requisite is having 6 of those throughout the brain.
Excellent. And then the paramagnetic rim lesion, that's right there.
There you see, so it's dark, and so probably related to iron deposition there around the lesion. So you get a rim of hypodensity, so it looks dark, like you see there.
Excellent. And we always talk about, you mentioned the acute lesions, the one that enhances with contrast, and we'll look at that as a sign of acute inflammation, right? That inflammation.
Yes, and this is a great picture here. So this is like characteristic of MS. So the top left there, Dr. Shoemaker is showing us one that enhances, and the enhancement in MS tends to be a ring, and it tends to be like an open ring towards the center, towards the corpus callosum. And then you have another one that is just like a round area of enhancement right next to it. And so those are very specific for MS. And then in terms of the T2 lesions, I like the one on the left that you are showing, this sequence on the left that is a sagittal flare. This is like my favorite sequence for helping diagnose MS, because it really gives us, so it's a sagittal sequence, it's a side view or a profile view of the brain and the corpus callosum. And this type of sequence is excellent for showing in that in those little veins that get into the corpus callosum and cause that shape of the lesions being like little they call them Dawson's fingers, so little fingers sticking out, and they stick out from the ependyma of the ventricles. And that is very specific to MS. And we try to contrast that with the white matter ischemic disease that we see more commonly in the general population that doesn't attach to the ependyma in that way and doesn't stick up perpendicularly from the ventricles, but it's more those non-specific and T2 hyperintensities that are not round, not ovoid, they're irregular, they're disconnected from the ependyma of the lateral ventricles, and that helps us reassure patients that that's not an MS lesion versus this type of lesion that has the typical shape and location and orientation and size that we look for multiple sclerosis.
So, Dr. Schneider, what you're saying is there is a lot of science behind the morphology and the shape of the lesion. So when a doctor that understands MS look at the MRI says, that doesn't look like MS, it's not that you have a crystal ball, right? You're looking at all of these different things like the size, the shape, the location, the signal intensity, and there are so many factors that go into that. But we can still make mistakes, right? On saying, well, that doesn't look like a MS lesion. So usually in those cases, what we do is do a spinal tap or do more testing. So what else came in the new criteria in terms of additional testing that we can do to help actually narrow down the differential into, yep, this is multiple sclerosis?
So yes, we can definitely use biomarkers like CSF, and the traditional finding that we look for is the oligoclonal bands, but here they say more than 2. And that I see different numbers for, but this is the criteria. But like in my hospital where I send it, they usually write in the report more than 4. But here it's more than 2. And then there's the kappa index light chains, which I don't think they're being done in all the hospitals that are doing the CSF, but I'm going to make sure that that's something that is added into our location. So that's even more biomarkers that help us confirm the diagnosis. And in my experience, I don't know about with you, but I don't do a lot of lumbar punctures. I usually try to make the diagnosis based on MRI. And when I do the lumbar puncture, it's more because I'm not able to make the diagnosis based on MRI, or the patient doesn't have the typical presentation that Dr. Shoemaker is showing here, which is the, younger than 50 years old, no comorbidities, and someone can have 2 things going on at the same time. They can have lesions from MS, but they could also have vascular ischemic, white matter ischemic disease, which makes it more challenging. And in those cases, I often then do a lumbar puncture because I need more ancillary information to help reach the diagnosis. But what I found is that I end up looking at the criteria more to help me rule out MS than to diagnose MS, because for the most part, thankfully, diagnosing MS is pretty straightforward. It's a young person that has a classic symptom, optic neuritis or weakness in a young person that shouldn't be something happening, or bladder issues. They're having a flare-up, an exacerbation. And then you see the lesions that fit all the criteria that we talked about in terms of neighborhoods, in terms of shape, location, orientation, enhancement, spinal cord involvement. But sometimes challenging is an older patient, as someone who has a chronic smoking history or has other conditions that could cause changes in the MRI, like lupus or other autoimmune diseases. Those cases, I might need to rely more on ancillary biomarkers and maybe look for those central vein signs and pearls or paramagnetic rim lesions.
Excellent. Well, this is very exciting. And one of the things that I'm actually excited about is not only the revision of the criteria will help us diagnose MS earlier in someone with minimal symptoms, but also there is this push now that because the pearls and the central vein sign are the type of lesions that are included in the criteria, most MRIs will have to include the sequences that will allow us to see these lesions and visualize them. And particularly when you look at the paramagnetic rim lesions, the ones that have that darker rim in the periphery of the lesion, those are actually lesions that are critical to look at the evolution of someone that is already diagnosed with MS, understand How are they doing? Are they accumulating more pearls? And what is the meaning of that as a predictor for disability? So now that we have these lesions included in the criteria, naturally it's going to force most MRI places to include the sequences that we need to be able to visualize those. And it's going to also advance the care of patients that are already diagnosed with MS. And in that note, I'm going to bring Dr. Shoemaker now into the conversation to say, well, what are the current kind of areas that you feel that are unmet needs in terms of therapies? You know, we went a long way from the times of the interferons to now highly effective therapies. In your opinion, what are those areas that we still need something?
Well, I mean, still the vast majority of our patients are people with relapsing MS. And so, a lot of times we say we've fully met the need for those patients, but there's still areas for improvement, and expanding the options are still great. But obviously the biggest unmet need is going to be for those patients who have longstanding established MS, have continued to accrue disability despite either being on highly efficacious therapy or having had stable MRIs. So I think that, progressive MS, PIRA, those are big areas where we are hoping to have an impact with therapy. And then there's the moonshot of obviously repair and remyelination, which would be either impact progression or reverse progression, or give our patients back those abilities that they've lost, or at least help them recover to a significant degree. So like those are probably our biggest unmet needs that are getting a lot of attention. Because I also think we're getting a little bit better understanding of some of the processes that are driving these, right? So we talked about pearls in the first part of it. And we know that there's these lesions that may have some degree of chronicity to them, right? So the idea is like maybe the pearl that iron deposition is due to chronically activated either macrophages or microglia eating up the myelin and having deposition there, right? And so where we have traditionally targeted our therapies, I know it's supposed to be a conversation, but why don't I throw up some slides? How about that?
Yes, please. I'm a visual learner, so I need to
Yes,
see it.
and also I'm not going to take any credit. I've stolen all these slides from other people at ECTRIMS, so don't give me credit. Give Rush credit for paying to send me there. Let's see here. Okay. Let's see here. Can we see my slide? Okay.
Yes, we can.
Oh, let's see. Let me go back down to it and jump back. So really for the longest time, our therapies have really been, this is the blood-brain barrier in the middle, right? And this is the blood vessel on one side and the brain on the other side, right? And historically, almost all of our therapies really have been targeting the peripheral immune response, right? Whether it be interferon, natalizumab, fingolimod, or most of our patients are on now are those anti-CD20 therapies, right? We've been targeting these cells in the periphery one way or the other. We're either directly destroying these cells, blocking their ability to cross over, or downregulating some type of genes or impacting their trafficking, right? So, we're seeing our B cells, we're seeing macrophages, and we're seeing T cells. But we know that's the driver of a lot of those new lesions. So for example, the central vein sign we talked about was because there's a vein and everything's coming through it, right? So that's the concept of central vein sign, is inflammation getting through the blood-brain barrier of that vein, right? But now the idea is, let's start targeting things that are actually in the brain. And the big thing we're worried about is that idea of smoldering inflammation, of chronic inflammation. And that's probably driven by multiple different cell types and processes. Like I said earlier, maybe there's some chronically activated macrophages. But the big thing that gets a lot of attention is going to be microglial activation, right? So microglia are the immune cells that are resident in the central nervous system. Basically, when you were developing as an embryo and a young baby, they went to the brain to take up residence and have lived there your entire life. But we know when the B cells kind of get in, the macrophages get in, they can upregulate the microglia and shift them into like this pro-inflammatory type. And the idea is being as they are chronically active, as they're chronically smoldering, they're probably directly injuring the axons of the nerves, leading to dysfunction, maybe leading to cell death and injury. So that's possible one process. And so the BTK medications, or Bruton's tyrosine kinase inhibitors, are a new class of medication that we believe work in both areas. They work in the periphery and the peripheral circulating immune cells, but they're small enough molecules that they can cross over. And so the idea being that there's BTK, this enzyme in the B cells, macrophages in the periphery, which it can target, but then it can get into the central nervous system, target them there, and then target the actual microglia within the central nervous system. And so as a result, we've got all of these molecules that are in some stage of development. Remibrutinib, evobrutinib, tolebrutinib, fenibrutinib, orelabrutinib, right? So some of these are phase 3, some of these are phase 2 and earlier on. But they're all in some aspect of development. Tolebrutinib is the one that you'll hear the most about because it has the most data that we can crunch through and is the closest to approval. So one of the things that I really learned that I thought was important at ECTRIMS was that not all BTKI medications are created equal. And that was a learning point for me because we have an analogous situation with our anti-CD20 therapies, our Ocrevus, our Briumvis, our Kcentas, our rituximabs, right? And the truth of it is probably they're all essentially equal. They're very hard to differentiate them. There's obviously small margins of differentiation, and a lot of that's going to be patient preference. But in the end, they're pretty clinically efficaciously equivalent. They all target your B cells, they pop them, your body grows them back. Pretty simple. That's probably not necessarily the case with the BTKIs, right? And so that's why we're probably going to have to look at each individually and with a discerning eye to see really what they are producing. And so these are just a couple, complicated images driving home that point. And so one of them is basically just showing the different BTKIs and what they're actually inhibiting, right? And so one of the things I walked away with is that the remibrutinib might be one of the cleaner ones. And the idea being that remibrutinib is targeting only a couple different enzymes, and it does a pretty good job of occupying the receptors and suppressing those ones specifically. I should note that I'm a site PI for a remibrutinib study, but I'm not using this as a reason to recruit. I was just bringing that up.
Dr. Shoemaker, let me ask you a clarifying question. By cleaner, what you truly means is they're selectively targeting the enzyme that you want them to target and not targeting other enzymes in the rest of the body that will cause more side effects. Is that correct?
That is a much more thoughtful way of stating it than what I just said. Yes, it's much more, the targets are more specific, right? And that's what we're seeing here. We're getting BTK and TEC with remibrutinib versus tolebrutinib. We're getting a lot of BTK inhibition, but we're also getting a lot of other enzymes as well too. And that's one of the ideas that these are enzymatic inhibitors. We're actually targeting a specific process, right? So the thought process, maybe this will be more efficacious or maybe less side effects. We'll actually show you eventually, we hope, the clinical results and how they're different. But then it's kind of showing that the actual occupancy of the BTK enzymes are different with each molecule, and their effects over here on B cells are different in vitro. So the idea being that while they're all molecules that belong to the same class, their end result may ultimately be different, right? And that's why we really will need to look at the clinical trials and parse through the results.
And so, sorry to interrupt again, but I think what you just said gives a lot of hope. And the reason I'm saying that is because evobrutinib, which is in the middle of your screen here, was the first BTK inhibitor to release phase 3 data. And unfortunately, not all, but most of the data, particularly their primary endpoints, didn't meet the expected results. So that's why the drug is not approved.
And again, we should say it didn't meet its expected results because it was trying to prove superiority of it to another medication.
Right.
And so it's not even to say that it didn't work. It just didn't work good enough to justify its approval, right? So it does something. It just doesn't do enough to really say, hey, it's worth getting approval in what they were trying to approve, right? So Even that one medication that potentially failed still had an impact.
Right.
But then this is going back to what I said about the tolebrutinib experience, right? And so, you know, actually, we just had ECTRIMS, so I'm showing you some kind of old data, but this is what we were discussing while we were there, right? And so this is Gemini 1 and 2. This is tolebrutinib looking at relapsing MS. And this is looking actually at their outcomes in disability progression. And the idea being this is a secondary endpoint, but even in a relapsing population, that unmet need of halting progression or slowing progression, we started to see differences in a relapsing MS cohort, right? And so while this wasn't the primary aim of the study, you could see that there was a difference in pure disability progression. Now, again, this is also meaningful for data I'm not showing here, but their differences in MRI outcomes and relapses were not significantly different. But there clearly is a difference here in disability progression. And so this suggests that maybe, going back to this slide, out here is what we think drives relapses and new MRI lesions. And here might be what drives disability progression, right? And so tolebrutinib and Aubagio or teriflunomide look pretty equal out here, but there's clearly something different in here, we suspect, with this study, looking at this relapsing study. But then we also had the Hercules study, which was much more specific and looking at patients with non-relapsing secondary progressive MS. So going back to the question of like, where are our unmet needs? Well, this is one of those interesting things where we really can't impact progression to the degree we would like. But this is looking at patients at 45 months. Now, in non-relapsing secondary progressive MS, we don't have a standard of care, so we have to compare to a placebo. But in this, there was clearly a demarcation between the two groups early on that stayed throughout. Potentially more importantly to our patients is that those patients on tolebrutinib were more likely to see improvement in their disability, right? Again, this isn't what the study sought out to prove definitively. It was a disability progression. But ultimately, we're hoping for our patients to stabilize and have the opportunity to improve. And again, we can see that there was a difference in these populations with improvement in the tolebrutinib study.
So, Dr. Shoemaker, can you tell us, for example, what will be a typical patient that fits these criteria? That, you know, when you see them in clinic, what will be the typical story?
Well, that's the hardest question of the night, right? Because defining progression is difficult, and it really is. And I think sometimes I simplify it to my patients like, well, you've had MS for a while, your MRIs have been stable, you haven't had a relapse, but when we compare you to a year ago, you're not quite as good. Your walking is slower, your arms are weaker, your foot drop has gotten worse, and we don't have a clear explanation. Obviously, if you were hospitalized for pneumonia or a shark bit your leg, you've got an explanation. But if we don't have an explanation, you're worse. You know, that's kind of how we define progression. Now, a typical patient, you know, they're usually going to be our slightly older patients, right? They're going to be our patients who have established MS, right? They at one point had relapsing MS. Now they have secondary progressive MS. But also, we don't quite know if the FDA is going to approve it, and when they're going to, and what the package insert and prescribing guidelines are going to specifically be. And so this was the new piece of data at ECTRIMS was that the FDA announced that they wanted more time to review the data before kind of making an announcement for approval or not approval of the medication. And so I believe it's been delayed until late December, so probably very early next year as we'll have a better idea. But this already seems like it's more in line with the EMA, the European Medical Association, was going to be making their judgment. So hopefully it puts us in line, and we'll see. Obviously, we're talking more about the excitement stuff. We're not talking about side effects right now. That's kind of a little more of a detailed discussion for another point in time. I would just say broad strokes. It looks, in the vast majority of patients, it looks as like a very good safety profile, with the small exception of potential liver enzyme abnormalities, which that's probably going to be part of the plan, is how the drug companies are going to monitor for that.
Excellent.
But we're talking about BTKs. There was other BTK data there that was published. So I just want to talk briefly about another one. So that was tolebrutinib. Now another company's got fenebrutinib, right? And this is looking at patients with relapsing MS, right? So we said, oh, we're worried about progressive MS, and this one didn't do so great in relapsing MS. Well, actually, there's another BTKI that looks like, hey, perhaps it did have a bit of an impact in progressive MS. So, for example, we're looking at annualized relapse rate, and these are past the initial study, so it's out to week 96. Open label extension, they're just looking at the overall annualized relapse rate initially versus placebo. Open label extension, and they're seeing continued low rates of relapse in this population. This is all preliminary phase 2 data, but showing that perhaps we'll see some impact in utility for BTKIs in our relapsing cohort as well too.
So this is excellent news and very exciting actually to be able to understand the biology of MS, and you were excellent in explaining the outside of the brain, inside of the brain. How about age? Is there any age restriction in terms of how old a patient needs to be or young in order to access this type of medications?
I don't know. Do you have any concept of what the age limits are going to be for these?
Well, so unfortunately, the clinical trials usually put an age limit, and
usually
they were
55 to 65. But again, I don't know what the FDA is going to tell us about these patients.
Usually the FDA approves the drug and leaves the decision to their healthcare providers on age limit. I will say that probably early on we'll be a little bit more careful, understanding that the side effect profile might be different depending on age. But I think it comes down to our ability to also diagnose progression in MS. And if someone is progressing this or getting worse despite maximal efforts, probably will be a good candidate to at least try this option or this alternative.
When I look at it, with our older patients, again, we can talk about this another time, but age is probably one of those independent risk factors for progression, right? We know age influences progression. And with a lot of our DMTs, we worry about age-related side effects, for example, increased infection risk, right? So we know that's a potential risk factor for people on prolonged depleting agents, right? But a lot of the safety signal we're getting from the BTKIs isn't necessarily around infectious risk.
Right.
And so that may give us a little bit of comfort in using these in patients that are a little bit older. And so, when the trade-off of risk versus benefit has a significant risk component from infection, then I'm a little bit weary about some medications. But if we continue to feel comfortable with the risk of infections in these patients, I might get pretty generous, I'll be honest.
Dr. Shoemaker, I wanted to highlight 2 points that you made. One is that, I agree 100%. What I also learned from this conference is that with this new class of medications, it's not like the B-cell therapies where they're all very similar. It's not like the interference where they're all very similar. So it's not just that they target different enzymes, but they also have different effects on the relapses, the inflammatory component, and on the progression. So what I've been debating with this new class of drugs is that we already have, with the B-cell therapies, very effective. There's very little room for improvement in terms of attacking the inflammation. And so I was thinking that they would, with this new class of drugs, they would try to focus more on the unmet need, which is the progression. But they keep designing the studies where they're looking at relapses first, and they have a hierarchical endpoints, and then the disability comes second. And now with fenebrutinib, which seems to be also very effective for inflammation, I think we're going to go down the same path. So when these drugs get approved, how are we going to position them? Where are we going to use them? Are we going to use them after B-cell therapies? Are we going to use them in combination, if that's allowed? How do you...
It's funny because we've talked about sequencing of DMTs forever, right? Like as soon as we start getting depleting agents and high efficacy agents, we're always like, well, we'll do an induction approach and then we'll taper off and do a maintenance approach and we'll switch DMTs. And in the academic sense, it always sounds so great. but I rarely ever done that with a patient in front of me where I'm like, well, we've depleted you, we've taken away the inflammation. Now let's go into a maintenance phase. But now, I don't know. I think we have more understanding of the role of depleting agents and maybe the duration on them, and there might be a trade-off at some point in time. So we might start doing more of a sequencing approach once we get a little bit more information and comfortable. This also might be the type of therapy where those, where we've got maybe some transitional patients where you're not, you think they're probably established, relapsing, remitting. They don't seem like they've got the most inflammatory phenotype. You don't really think they're progressing, but they're pretty stable. And so if you can get something that can protect you a little bit against or a lot against the relapses, but also protect against future disability progression, that might be their role, right? There's the Loveland criteria always add on this other nomenclature, right? And there's that relapsing, remitting, like inactive subtype, right? So perhaps maybe that's what these are meant for, is that patient where you're not worried with their MRIs going to show any new lesions. You're not expecting them to continue to decline, but you want to protect them on both ends. So perhaps it's this transitional period.
So this is excellent discussions to actually to the level of ECTRIMS. I really enjoy this. And I see some questions in the chat box, some around, is this going to be instead of or in addition to CD20s? No, most likely it's going to be instead of. Very unlikely the drugs will be approved as combination therapy. So as Dr. Shoemaker and Schneider mentioned, it's going to be on a case-to-case basis, right? So we don't know the typical profile of a patient. And I'm not aware of any age limit, as we mentioned before. So the length of disability or length of MS should not be an impediment in the right clinical context to use this. And just because we have a few minutes left, Dr. Shoemaker, any exciting news on reparative remyelination therapies? Any other mechanism of actions, perhaps, that we want to talk?
I mean, I got a lot of kooky stuff I wanted to talk about, so I'll try to get through some of it. Okay.
All right, go for it.
Let's see here. So this is a study that I thought was kind of cool. Oh, where'd it go? So this wasn't necessarily remyelination, but it was, again, trying to target PIRA and microglial activation. This was foralumab. This is like a Harvard child, I believe. It targets, I think, anti-CD3. But what I think is really interesting about it is that it's nasally administered, right? So this is a nasal spray, and it's an interesting concept because as neurologists, we don't talk about this much with our patients, is that the easiest way to get to the brain is through the nose. It has a very thin barrier. You can apply things and it immediately gets in. And they did show some changes and some actual evidence that it was exerting influence in the central nervous system. So I thought that was a really interesting study about potential kind of different approach and paradigm. So this is just a quick look at all of these efforts at remyelination and neuroprotection. There's a lot of interest. Things are kind of slowly making progress, right? But they did talk about two results there, right? And both of them are coming out of Cambridge. So they've got the Cambridge Center for Myelin Repair, CCMR. And both of the studies that they presented were really nice because they're building on prior studies. So we've known about clemastine for a little bit of time because of the work out of UCSF. And there's a lot of validity into this approach and what they're targeting. And so what Cambridge did is they looked at clemastine and they added on metformin. And the idea is that metformin potentially, by how it works at metabolic targets, may open the pathway for which clemastine can come in and then promote remyelination. And the whole point of all this, though, is that these are readily available now therapies, right? And so we could wait for one of the big drug companies to bring therapies all the way from in vitro models to phase 3. That's going to take decades. Their concept was like, let's see if we got things already available that could influence patients, right? Now they're using a surrogate marker of remyelination, and they're looking at visually evoked potentials. They're trying to use full field VEPs, with the idea being that if we're seeing remyelination, we can influence the speed of nerve transduction. So basically, unfortunately, they did not see any significant impact in patients treated with this combination of pills. So it had, is well thought out. It had a lot of promise, but the idea being that maybe we could infer some remyelination. But unfortunately, it just didn't have a meaningful impact. They also looked at, so this is looking at the different groups and how it affected the latency of the visually evoked potential. And you can see the treatment group, the nerve conduction was neither faster nor significantly stronger. Now, they did make a good caveat, is that remyelination is a process we're totally unfamiliar with from a clinical side, and we don't know what time frame it really takes place in, right? So there's a chance that these studies are just too short. I mean, our disability studies are often studies that require a long time to see impact, and so it's a possibility that we may just need more time to see something meaningful, and so they're going to continue to follow these patients.
And the interesting thing of the combo is that, clemastine is one of those compounds that actually thought to help differentiate the myelin-producing cells into becoming more active.
The OPC, yep.
Right, the OPC. So whereas metformin, what it's doing is working at a different level, whether it's mitochondria in the oligodendrocyte-producing cells, but also in reversing some of the age factors that play a role into decreasing the ability of the oligodendrocytes to remyelinate. So when you add the two, it has this synergistic effect that actually is interesting. But in terms of side effects, if a patient asks you, can I take clemastine over the counter? What is your response these days?
Well, we tried that when the first clemastine studies came out, and we had a lot of difficulties because it's anticholinergic with side effects. And long-term anticholinergic use in our patients is not something that we want due to the side effects and the risks associated with them. But surprisingly, in their study, when they reported AEs, their reports of lethargy were quite low. But in the few people that had it, it was debilitating, right? So
right.
I'm not quite sure if that has been my experience with clemastine or any anticholinergic in the past, but they said their rates were low, but in those that experienced them, it was debilitating. But then the same kind of group had another study where they're looking at this other agent, I think it's bexarotene.
Mm-hmm.
And so they were looking at its influence, and they try to look at both its influence on serum neurofilament, which is a marker of nerve injury, as well as visually evoked potential. And here they basically were able to draw out potentially some benefit in VEP. It also correlated with reduction of neurofilament light chain level. And so they think there may be some plausibility with this. So there'll be more to come, I think, from this group with this agent. Because we're low on time, there's two other things. One is because this is brain health, we should point out that one of the biggest impacts in remyelination was a study looking at aerobic exercise. And so this is kind of the model which aerobic exercise might influence. And so they randomized people to aerobic exercise versus a control group. And then they looked actually at brain regions, and they saw increased basically water density within heavily myelinated areas of the brain. And they saw improvement in those that were randomized to aerobic exercise. So, and I think, no. And so that was one of the things where, again, this isn't a medication. This isn't something we have to really prescribe. This is something that's readily available. Now, getting out there and doing it is harder than me just telling you to, but this is something that is readily accessible and showing impacts on brain volumes and size and potential surrogate markers of remyelination.
And on that note, Dr. Shoemaker, let's remind the audience that we currently have guidelines that have been published as early as 2018. But the mistake of the committee is to call them the Canadian guidelines for exercise in MS. And people think that only works for Canadians. They actually work for everyone. And these guidelines are going to be revised soon. So we'll give you an update. But actually, they're as little as 2.5 hours per week for 6 months is the current recommendation. Of course, we actually prefer to see half of that being aerobic, the other half being strength training. And as you get older, we change that a little bit for more strength training as you age. But it actually takes a little effort, but actually is doable. And the good news is that even if you have mobility issue, exercising whatever limb you can move, it's going to give you the same benefits. So it doesn't have to be a treadmill or walking. It could be just simply moving one arm, as long as you do it in repetition and with consistency. And what else, Dr. Shoemaker? What else you have for us?
For the sake of time, I don't know. I think Kathy is looking nervous about me talking for longer. I don't know what your thoughts.
No, that's not it at all. But there were actually another question that I think that might be really good to ask you. So could any remyelinating medications be administered through like a baclofen pump?
I mean, ultimately, that would be an idea. I think the problem is like the difficulty with that type of administration, but it all depend on the molecule and how they think it'll work, right? And so everything we've had to date that looks promising has gone up through the phases of development, either as a pill or an intravenous infusion, and now possibly intranasally. And intranasally, again, it may be a very promising route because it is maybe the easiest way to get certain larger molecules into the central nervous system.
Excellent. And I saw a question too about hormonal replacement therapy on the chat box. Not a lot happened during ECTRIMS about HRT. What we know is that there was a presentation on brain atrophy rates increasing in postmenopausal women, kind of matching the level of men, suggesting that estrogens and hormones in general may have a protective effect also on brain volumes. If you want to learn more about hormones and brain health, I encourage you to listen to our May conversations on brain health that we devoted an entire hour discussing hormones and hormonal replacement therapy, testosterone in the care of MS patients. Anything else, Kathy?
There was a question that came through that asked, does clemastine increase disability progression in some MS subgroups?
So that was some of the data published at another point in time that was maybe concerning for that. Again, the disability progression, in my guess, was probably likely driven to lethargy and side effects. But what they presented was totally contrasting other studies and experience, and that tolerability was high with their study population. Perhaps metformin offsets some of this. Perhaps it's that stiff upper lip of the British. I don't know why they did so much better, but that's what they were reporting.
Okay.
Excellent. And I see a question about memory. Can we improve memory at age 65? The answer is yes. And if you want to learn more about it, I'll bring you to the September conversations on brain health. We just did one session entirely on cognition and multiple sclerosis and brain health.
And for anybody who doesn't know how to access any of the historical YouTube videos, feel free to reach out to me directly, Catherine Kiefer, and I'll put my email address in the chat box in case anybody wants to reach out.
I don't know, Kathy, but I think that was an exciting meeting today. I want to thank Dr. Schneider, Dr. Shoemaker for sharing your updates, your passion for treating MS patients. Any final thoughts from each of you?
I think I'll go back to the diagnostic discussion, which wasn't what I talked about, but like everything is continuously being refined, and we're really getting better at recognizing patients with MS. And I think we're getting more precise in our diagnosis, but also our treatments. And I think we're getting to the point where we're really going to be able to personalize the way we approach individuals, which I think is very exciting.
Yes. And I just want to say that, yeah, I'm very excited for what you talked about with the new therapies and, meeting that unmet need and for those patients with progressive, secondary progressive, and primary progressive MS. Because I think we're doing a really good job with our very inflammatory patients in terms of controlling their disease and giving them a very normal lifestyle with treatment. But there's definitely a big unmet need that needs to be addressed.
I have to agree with Dr. Miravalle. This was fantastic. And I think it was really, really useful for so many to be able to hear some of the latest update information that came out of ECTRIMS. I have to say I was fortunate to be there as well, and just to see the amount of top specialists around the world all in one place, great minds talking about MS, NMOSD, and MOGAD is really quite incredible. And I love that things are just progressing in this area, just keeps getting better. On that note, I think we're almost at the hour, so I would like to highlight what our next month topic is going to be all about. So with November, there being Thanksgiving right around the corner, we will be talking about the practice of gratitude. So we will be joined by Adrienne Castillo, our nurse practitioner who runs our brain health clinic at Rush University Medical Center, as well as Laura Morris, who is a registered dietitian who will dive a little bit into some healthy recipes for the holidays. So that will be happening on November 10th, always a Monday, always second Monday of every month. So looking forward to having everybody back with us for that session. And again, I would just like to give a huge shout out to Dr. Schneider, Dr. Shoemaker, and Dr. Miravalle for bringing us this great session this evening. So hope everybody has a great evening, and we'll see you back next month. Thanks so much.
Thank you.
Thank you.
Thank you.